Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello again from Axxess headquarters here in Dallas, Texas. We are happy to present to you today a webinar on-demand content on PDGM, Patient-Driven Groupings Model Basics. This is your speaker, Jennifer Gibson Osburn. I'm a registered nurse with over 25 years of home health experience, as you probably know. Probably not new to you if you've been with Axxess very long or you've heard of our company. But again, we wanted to bring you some valuable information to help you prepare for a big disruptive coming change that will be happening for our industry in terms of how we are paid in January of 2020. So let's go ahead and get started. When we're speaking about PDGM industry-wide, there tends to be an assumption that we've all had time to study and understand what that is. But my goal today is really to help those of us who are busy on the day-to-day to understand the very basics of PDGM so that we can build on that knowledge and prepare for this change. Now, Patient-Driven Groupings Model is a new way of payment to begin January 1st, 2020. This payment system will replace the home health prospective payment system that we've currently used to bill that has been in place since 2000. And this change in the way that we're paid was mandated by the Bipartisan Budget Act of 2018. And more specifically, those particular things that were mandated by this law are that the therapy threshold for payment for home health agencies will be removed, and the way that we get paid will change from 60-day payment periods to 30-day payment periods. Now, all of this information came out with the final rule for 2019 for home health PPS. That was back in November of 2018 when they put the new tables out for home health PPS for 2019. There was also included information letting us know that in 2020 we would be changing our payment system to PDGM. Now, those of you who have heard of the changes in the payment system before, you've been kind of keeping up in the last few years with all the recommendations made to CMS by MedPAC and other research and studies and such, you may be familiar with some of the concepts of PDGM, which was formerly called HHGM. So let's continue to dig in and understand what the provisions of PDGM are. The reason that we're changing payment system is in all the research and studies and data analysis and such, there was a disparity between certain agencies and the acuity level of patients and access to care for certain patients who had more acute conditions. So what CMS is trying to do with PDGM really is to align the payment with the cost that are incurred by agencies. They're looking to make compensation fair for agencies and eliminate some of the cherry picking that might go on. Just getting those patients that are easy in, easy out, lots of money, lots of therapy, and unfortunately for our industry and for our patients more specifically, that has become a trend in some areas that agencies don't take the more acutely ill patients. So in paying us more fairly, what CMS is trying to do is make sure that patients who are more acutely ill can receive home care as well as those who are maybe less ill. And as we said earlier, we're really, because of the law, eliminating that therapy-driven payment and incentives. We're getting away from paying for volume and paying instead for quality and for outcomes for our patients. Now, PDGM will be grouping patients into a clinically meaningful payment category. We currently have payment categories now that are called HIP scores and HERG scores, home health resource groupers. We will still have those home health resource groupers, but they will be based more on a clinical picture of the patient rather than the volume of care. And all of this will impact the quality of care that's given to our patients as well. In our current home health PPS system, home health prospective payment system is what that acronym stands for, we see that that system produces lower margins for patients who need non-oral nutrition, things like TPN or G-tube feedings, nutritional feedings some way other than by mouth. We also see that we don't get paid as much for patients who have traumatic wounds or ulcers. Patients who require substantial assistance in bathing, we don't get paid as well as we should for those. Patients who are admitted to home health following an acute or post-acute stay, which makes sense because those patients are typically more acutely ill than the majority of patients who are referred to us from the community. Now, the one little exception to that is the patients who have been in the hospital within the last week or so. They go in and see their physician, their follow-up provider, and they end up getting a referral to home health. Those are, they're still acutely ill, but maybe not quite as much as when they first came out of the hospital. So we're going to be looking at that as well. So our current home health PPS system, when we look at how we get paid under home health prospective payment system, the data and the research shows that agencies get paid lower margins for patients who are more acutely ill, as we've said. Those include patients who need non-oral nutrition, like TPN, or they have tube feedings, G-tube, J-tube, that kind of thing. Also, patients who have traumatic wounds or ulcers. Those patients who need a lot of assistance in bathing, those patients who are admitted to home health after they've been in an acute or a post-acute facility, which makes sense. Those patients tend to be more acutely ill. More resources are needed, especially in the first period of weeks after the hospitalization to keep them from going back to the hospital. Those who have a higher category score in the condition hierarchy, those patients tend not to be paid as they should be when you compare cost to actual money that we are making for those patients. We also see that that's true for patients who have certain poorly controlled clinical conditions. These are usually chronic comorbid conditions, for example, and those patients who are dually eligible, which means they have Medicare and Medicaid. And when you think about the complexity of those patients with their socioeconomic status, their chronic conditions, you're looking at really complex patients on this list who tend either to be turned away from home health or they tend to be too complex. Agencies tend to shy away from those patients because the cost is prohibitive to care for those. So what will be the impact for payment under PDGM? Well, when the law passed, what was introduced as part of the laws for the Balanced Budget Act, Bipartisan Budget Act, that is that this needs to be a budget neutral approach so that there's not a big impact to agencies and our income. We will see RAPs continue with some exceptions. We're going to get into that in a bit. LUPAs will remain with some changes as well, primarily in the threshold for the number of visits that create a LUPA. Our PEPs, or partial episode payments, will be maintained in this system. So if a patient transfers from one agency to another during the 60-day episode, then that PEP will go into play as well. And then the outlier policy is also maintained under the new payment system. Now, this slide I wanted to show you is pulled from some of the CMS research and data. It just goes to prove a point in that when CMS and MedPAC and all of those big entities there in Washington have a look at the data from home health agencies, what they see is that we tend to front load visits, and we also tend to disperse those visits over a 60-day period according to the discipline that's in the home. For example, on days 1 through 15, average-wise, there are about 8.1 visits. And you'll see as you go from 16 to 30 days to 31 to 45 days and 46 to 60, that visit count continues to go down. And you'll notice the trend in front loading with nursing visits and then therapy visits and so on. The reason that's important to know is that when CMS is looking at the data, what they realize is that we do tend to front load an awful lot, and a lot of the care that we get paid for happens in the first 30 days of an episode. And then we tend to taper down and get the patient ready for discharge. Additionally, nationally speaking, most agencies discharge patients well before, in most cases, the 60th day has happened. There tends on the national average to be not as many research has happened in certain pockets or hotspots in the country. Now, some of that can be explained by perhaps the number of retirees that are in an area. Certain climates tend to attract retirees. They don't tend to move to places where it's terribly cold, with the exception of Chicago. For whatever reason, they still have a lot of Medicare beneficiaries up in the Chicago area. But you certainly see a lot of Medicare beneficiaries in Florida, Texas, California, Arizona, Louisiana, places like that, where it's warmer year-round. But all of that just to say that nationally, the trend is that we see a lot of front loading in the first 30 days, tapering down the last part of the period, and that nationally, average-wise, we are looking at outcomes, getting the patient on the services, getting them the help they need, and then getting out. All right, so let's begin looking on a side-by-side level at the differences between Home Health PPS, which is our current payment system here on the left, and Patient-Driven Groupings Model, which is our coming payment system on the right. Now, one thing that will not change is our documentation period. By documentation period, I mean literally when we do our comprehensive assessments, when we think about episodes, and this is not the quality episode. This is what we currently have as a payment episode, a 60-day payment and documentation episode that's combined. Under Home Health PPS, we do our comprehensive assessment every 60 days. Our unit of payment is every 60 days as well. The thing that's different, one of the things that the Bipartisan Budget Act law mandated is that the payment unit goes from 60 days to every 30 days. So our documentation period is still 60-day episodes under PDGM. The comprehensive assessment has to happen at least every 60 days, but the unit of payment will change to 30-day periods. The payment rates will change as well. Currently, for 60 days, the national standard 60-day episode payment rate is $3,154. And then in addition to that, there's a separate grouper that calculates your non-routine supply money. That payment's added on each 60-day period, and that can range anywhere from about $15 to about $570. Now, this payment in Home Health PPS that we're currently under, as we all know, all of this comes from our OASIS, which is why OASIS accuracy is such a big deal and coding's a big deal, and so on. It becomes even more so, however, when you look on the right-hand side over here, Patient-Driven Groupings Model. For each 30-day period, we're looking at an estimation of about $1,874. So that's the amount that we're looking at preliminarily. That's what's been proposed so far. It will be a formal proposal that will come out, and it may adjust that rate when we see the proposed rule in July. And then it will be finalized, whatever that payment proposal is, will become finalized or maybe adjusted again in November of this year to get ready for 2020. But anyway, whatever that proposed national rate is, this is before we are assessed a 6.425% decrease for behavioral adjustments. And what that decrease is basically is an authorized reduction in payment by the Bipartisan Budget Act. CMS was given authority to cut payment on what they assume our behaviors will be. For example, it is assumed that agencies will cut therapy visits, for example. They'll say, oh, we're not going to get paid for volume or paid by the number of visits for therapy. Well, we just won't do as many therapy visits. And because that is typically how our industry responds to changes, we adjust and figure out a way to make money. CMS is saying, oh, well, we'll just cut that off the top because, rather than paying them and having to try and recoup that later, we'll just take that across the board, and then the adjustment won't affect us, and we'll still have the outcomes that we need without overpaying the agencies. And additionally, there is no add-on calculation for non-routine supplies. Those supply costs are already built into PDGM. They're already built into the payment rate. Now, again, the actual rate will be set in 2020's payment final rule, and that will come out in November. All right, so how's the cost calculated? In other words, how do they figure out how much money we should get paid per each payment episode? Under Home Health PPS, they look at the wage-weighted minutes of care from the Bureau of Labor Statistics. What does that mean? That means basically they take hospital-based wage information for each of the kinds of disciplines, nursing, PT, OT, speech, so on, and then they look at that hourly cost and they multiply that by the number of minutes that we spend with the patient, and that's kind of how they calculate a hourly rate, or I should say an hourly rate, and then also the total cost of care. But they don't consider the overall cost of running a home health agency or making a home health visit, like transportation costs and mileage and keeping up with the office and all that. It's strictly a wage-based multiplied by number of minutes. So costs are aggregated for the home health service industry. Now, under PDGM, this is another significant change under the new payment system. It is a cost per minute plus non-routine supply calculation. But the new groupings model incorporates a wider variety of costs. Like, it does take into account mileage and transportation and all that. And these costs are available for individual home health agency providers. Well, guess where they get the information to drill it down to each home health agency? That comes from your Medicare cost report that we have to do annually. So we have to make sure that those cost reports are accurate. And we've been talking about that for many years now, if you've been to any of my classes, because the cost reports have typically always been used to calculate payment in some form or the other, maybe not so much for the actual episode payment. But when we look at how we get paid for supplies, for example, MedPAC refers us to our own cost reports and says, you know what, you're not getting raises for your supplies because we don't see those supplies reflected on the cost report. You might get them on your claim or you might not, but they're not well accounted for, and that cost is never really transferred over into the cost report as an industry. So since you're not showing us how much it really costs you to take care of the patient with your supplies, then we're not giving you extra money. So now that we see that our patient-driven groupings model is going to actually have the ability to drill down on an agency-specific level and calculate our cost, we need to make darn sure that they are correct. This little table is just another way to visualize the differences between the different types of payment approaches. Again, your data source for current wage-weighted minutes of care and cost per minute plus non-routine supplies. On the right-hand side here, that's under PDGM. The middle column there, the wage-weighted minutes of care, that's how it's currently calculated under home health PPS. So it's data sources. In PPS, we have the Bureau of Labor Statistics. Under cost per minute, it's going to be your Medicare claims and cost reports. The general approach, it's in home health PPS, wages multiplied by the amount of care that's given per each discipline. Whereas in PDGM, it's going to be the total cost multiplied by the amount of care provided for each discipline. And cost represented on PPS is just the wages and fringe benefits only that are related to the patient visit. However, in PDGM, we're looking at other things: wages, fringe benefits, overhead cost, transportation costs, and other non-visiting services labor costs. They're taking into account the office staff that we have, especially in those states where we're going to have to do review choice demonstration, for example. When we reflect the cost of how much more help we have and how much money we're spending on getting that paperwork together, that data will be backed up with our cost reports if we're doing that right. And then non-routine supplies, as we've said, they are already calculated into the PDGM model, whereas they're in a separate model, a separate add-on under our current system, home health PPS. So what's the advantage of these two cost types? Well, on the left-hand side under home health PPS, because they're using labor categories, they can look at the difference in cost between RNs and LPNs. And we saw that, of course, with our G codes that were added several years ago, that on our bill shows the difference as far as which visits are made by RNs versus LPNs and LVNs and PTs and PTAs and so on. That's so that they could look at the data and the cost and all that stuff. Now, the Bureau of Labor Statistics, that data is available more quickly than our cost reports. But there's no imputation of resource use versus cost needed under home health PPS. However, under PDGM, we see that all that's integrated into one payment model, which is based on the patient characteristics, and then will be spit out in this one payment system. It incorporates more than just the visit cost for us, and then there's a lower ratio of nursing to therapy cost. All right, so let's look at the case mix structure. We've talked about how the cost is going to be calculated. How are they actually going to now figure out which categories to put patients in so that we know how much payment we're going to receive for those patients? Currently, under home health PPS, we know that with the patients placed in different groupers based on the admission source and timing, and that comes from your OASIS. Then we know that there's another part called the clinical domain, and that comes from OASIS answers. Then we have a functional domain, which comes from OASIS answers. Then we have a service utilization domain, and we have a non-routine adjustment calculation, and all of those together spits the patient into one of 153 home health resource groups, or HERG scores. Under PDGM, you still have an admission source and timing, and that's going to change as far as what that is. Because we know currently under home health PPS, that is based on if it's an early or late episode and how many therapy visits. That's what puts the patient in one of 4 different groupers to calculate your clinical functional service utilization. Under PDGM, since we know the therapy calculation's coming away, then the admission source and timing is going to be different. We'll talk about that in just a moment. Now, again, admission source and timing, that no longer comes from our OASIS either. That's going to come from claims data. So we anticipate there might be some delay sometimes with whether or not the patient came out of a hospital, whether or not they've done their billing, the hospital or facility has done their billing and it's in the common working file and so on. So we have a lot of things to think about, and we're going to talk about that in subsequent webinars, but right now we're just talking about the basics. Just know that the admission source and timing calculations will be different because they're no longer therapy driven. Your clinical severity is also going to come from the diagnoses. However, the change is rather than the clinical domain coming from the top 6 diagnosis, it only comes from the primary diagnosis or the primary reason for home care. That diagnosis alone is what will dictate clinically what this patient's needs are and how they're going to fall in the grouping categories. Okay. Then we've got the functional severity, which will continue to come from the OASIS M items at this time, and they might eventually segue, in my opinion, into the GG and J items that were introduced this year, because the skilled nursing facilities are also going through a change in their payment model called PDPM, and they are using in that setting the GG items to calculate their functional severity. So wouldn't surprise me that that will transition over to home health unless we can very well prove and lobby that those questions don't make a lot of sense in home health because we are not in a controlled environment and our outcomes will be different, right? I digress a little bit there, but you see what I mean. And then you might have a comorbidity adjustment, which will come from the secondary diagnoses on the claim. Now, all of these different pieces of information will put the patient into one of 432 home health resource groups under PDGM. So you'll see the HERGs break out into a lot more categories. This little diagram is just an overview of home health PPS. We see that the clinical aspect of home health PPS, or the clinical grouper, comes from the clinical indications on the OASIS, things like the primary diagnosis, whether or not they have an IV or they have enteral therapy, whether they have problems with their vision or wounds or pressure ulcers, the stage of those pressure ulcers, whether or not they have stasis ulcers and surgical wounds and they're short of breath and they have bowel incontinence and drug use and so on. And I don't mean that recreationally. Of course, injectable drug use, right? That information plugs the patient currently into either a low, moderate, or high clinical threshold, C1, C2, C3. Then you go in and you also add your functional scores, which comes from the items that address dressing, bathing, toileting, transferring, locomotion. Those answers then calculate and put the patient into a functional low, moderate, or high, F1, F2, F3. And then your service utilization, which is just based on the number of therapy visits, 0 to 13, 14 to 19, or 20 or more. And then at final bill, the actual numbers looked at, and that puts the patient in a service utilization group S1, S2, S3. Because of the different variables here, that will calculate into one of 153 groups. Under PDGM, let's look at this diagram, for example. Instead of, in home health PPS, early, late, plus number of therapy visits, calculating your admission source and timing, it will be early, late, and whether or not the patient has been in an acute or post-acute facility in the last 14 days before admission. If they've been in a facility, that would be an institutional. If they've been in a community setting or the referral came from a physician in the community, for example, patient's not been in a facility is the key part there in the last 14 days, that will be a community referral, okay, or a community admission source. Now, let me say this because there tends to be a little bit of confusion. Well, we better mark it then to the hospitals. Don't forget, if that patient has been in a facility in the last 14 days, regardless of whether you get that referral from the institution itself or from a primary care provider, for example, it will still be institutional as far as the grouper is concerned. I say that because as you're looking at your processes, you may not knee-jerk and go out and try and get your referrals from just the hospital or the long-term care facility or whatever. What you will want to do is make sure that if the patient's coming out of a facility, whether you got the referral from the facility or the physician, that you have adequate documentation so that you can contact and ensure that that actually happened and find out what the date of discharge was. Because if you get that referral on day, let's say 12, after they've been in the facility, and you wait your 48 hours to go out and admit the patient, you might be out there past day 14. You might be going on day 15, right? Whereas if you got out there on day 13 or 14 after being discharged from the facility, now it's in an institutional, not a community. And guess what? The institutional pays more than does the community. In other words, because of the acuity that we talked about earlier, this patient's more acute in CMS's mind and in our research when they first come out of a facility rather than coming just from a community setting and they've not been in a facility in the last couple weeks. Okay, so I hope that makes sense. Then you've got your clinical grouping. Again, this only comes from the principal diagnosis reported on your claim. So depending on what the patient's primary diagnosis is on the claim, when that claim is submitted, CMS will calculate their clinical grouping based only on that primary diagnosis. And that diagnosis will dictate whether or not the patient goes into one of 12 of these buckets. The 12 buckets or the 12 categories are neuromuscular rehab, wounds, complex nursing interventions, musculoskeletal rehab, behavioral health, or medication management, teaching, and assessment. And that particular category is further broken down into 7 categories, which include your respiratory, your infectious diseases, your endocrine, your GIGU, your surgical aftercare, your cardiac and circulatory, and then other. Okay? Now, again, that means that they're basing the clinical category on the primary reason this patient's receiving care, which is what that primary diagnosis should be representing. All right, the only part that will continue to be from the OASIS under PDGM's home health resource grouping calculation is the functional impairment level, which is from the OASIS items. So the functional impairment level will come still from the M items. They're including a couple extra. One of them, for example, would be the grooming, and the other will be the risk for rehospitalization. Those will also help put the patient in one of the functional impairment levels of low, medium, or high. So each patient will be placed in one of those 3 categories. Lastly, you have a possible comorbidity adjustment, which will come from the secondary diagnoses listed on the claims. That patient can be put into one of 3. Either there's no comorbid adjustment, a low comorbid adjustment, or a high comorbid adjustment. So when you look at 4 times 12 times 3 times 3, that ends up giving us over the 400 different categories. So we looked at our diagram. Now let's look at the comparison of the timing in the 2 groupers. Again, for home health PPS, it's based on OASIS items. You have M110 telling if this is an early or late episode. Then you've got M2200, which is the therapy need, and that puts the patient in one of 4 groupers. The early grouper is the first 2 60-day periods currently, and late are all subsequent 60-day episodes. Now, for the patient to change from a late episode to an early episode, there has to be a 60-day gap between the episode periods. Under PDGM, our coming payment system, this is based on claims data. Your timing is still early, late, and as we talked about earlier, your admission source is community versus institutional, and that's based on where the patient has been in the last 14 days prior to your home health admission. That also puts the patient into 4 groupers, which are further broken down in the diagram. But the major change here is that the early episode is only the first 30 days under PDGM. That's it. Just the first 30 is early no matter what. Every other subsequent payment period, every other subsequent 30-day payment periods are late episodes of care. And again, you still have a 60-day gap before that resets from late to early, okay? So if the patient goes in the hospital, for example, on day 28 and they come out on day 60 and you've discharged the patient, you pick them right back up, it's still going to be a late episode, okay? That's what we know so far. This is just another way to show you how the groupers are added in Home Health PPS. Again, you've got your first and second episodes. That's an early episode, 0 to 13 therapy visits or 14 to 19 therapy visits. Then you get into your third and subsequent episodes. That's their late episode with 0 to 13 therapy visits or 14 to 19 therapy visits. Now, when you see that grouping step 1, 2, 3, 4, 5, and you look at your HIPS score, for example, and it's 1 BGKS, that 1 in your HIPS score is telling you that this is an early episode with 0 to 13 therapy visits. And when you're looking at your payment tables in Home Health PPS to see how many points you're going to get for diabetes as the primary diagnosis, you'll be looking in column 1 for this particular patient because it's a 1 BGKS, right? However, under PDGM, you'll see it's literally community early, community late, institutional early, institutional late. That's your 1, 2, 3, and 4 under PDGM's HIPS score. Okay, and again, remember, community means they've not been in the facility in the last 14 days. Early is the first 30 days of the episode only. Everything else is late. And institutional means the patient has been in a facility in the last 14 days, regardless of whether you got your referral from the facility itself or from a physician in the community. The institutional community comes strictly from whether or not there's a claim filed that says that patient has been in a facility in the last 14 days. Okay, now let's look at the clinical grouping. For your Home Health PPS groupers under clinical, it's based on a combination of OASIS item responses. And that puts the patient into one of 3 clinical severity levels, and that patient's either put in a C1 low, a C2 medium, or a C3 high. So when you're looking at your HIP score, this would be C1, C2, C3, and then that translates into A, B, or C. So for using that same HIPS code, 1 means it's an early episode, 0 to 13 therapy visits. B means it's a medium clinical severity. Okay, that's how that works. Under PDGM clinical, this is now based on claims data, and it's only based on the primary diagnosis. Now, here's a kicker for you, all right? The primary diagnoses that are acceptable, there are only 43,287 of the ICD-10 CM diagnoses out of the 94,000 plus that are acceptable under PDGM. Based on that primary diagnosis, that patient's going to be placed in one of those 12 clinical groups, and each of those clinical groups has its own severity threshold, low, medium, or high. So if it ends up in the wounds bucket of the 12, then wounds has its own low, medium, and high category within that, okay? Now, so what are those groupers actually coming from? Currently, for the clinical items, they're looking at M1021, the primary diagnosis, M1023, which is your secondary diagnoses, M1030, your therapy at home, 1200 is your vision, 1242 is whether or not they have pain that affects their mobility and their ADLs, 1311 and 1324, which asks about pressure ulcer number and stages, 1334, pressure ulcer stages, 1342 is the surgical wound status. 1400 is shortness of breath, bowel incontinence, ostomy that was related to an inpatient stay, and so on, and injectable drug use. So you can see currently they're kind of looking at a little Polaroid snapshot of the clinical picture of this patient. Under PDGM, it's only based on that clinical diagnosis, that primary diagnosis. Is that diagnosis going to fall into a behavioral health category, complex nursing, musculoskeletal, neurostroke, wounds, medication management, or where is it going to go? And again, don't forget that MMTA is further broken down into cardiac, endocrine, GIGU, infectious disease, neoplasms, blood forming, respiratory, surgical aftercare, or other. This is just another diagram to help us understand those clinical groups under PDGM. Now, if the patient's primary diagnosis places them in a musculoskeletal rehab category, when you're looking at musculoskeletal rehab and neurostroke rehab under PDGM categories, that means that they're already weighted heavier to accommodate the fact that the primary reason for home care in those cases are therapy related. They expect more therapy utilization, therefore they are going to pay more money for those categories. All right, for your wounds, post-op wound aftercare, and skin or non-surgical wound care, that would mean that the primary reason for home care in this case is to see after a surgical wound or burns and ulcers and lesions and all those other things. Again, assuming that the primary reason for care here is wound care, those are going to be weighted a little heavier to accommodate for the wound supplies and the non-routine supplies that are used. Complex nursing interventions, assessment, treatment of eval of complex medical and surgical conditions. This is going to include things like IV therapy. And so those diagnoses that are attention to a vascular access device will put the patient into this category, for example, and they know that there will be a lot more resources used for IV therapy and going out and see the patient and changing the PICC line dressing and so on. And those are weighted accordingly. Behavioral health care, assessment and treatment of psych and substance abuse conditions, that's another category, and it's weighted appropriately. And then you've got your MMTA, where the main reason that you're here in the home for these diagnoses is to assess, evaluate, teach, and do a medication management for all the different med-surg kind of conditions that don't fall into one of the other categories. Now, this particular group is the majority of the reason that we go out and do home health care. And what we're going to have to be good at as an industry will be to really think about how to efficiently provide those services with good outcomes rather than stretching them out over periods and periods and periods of care. The efficiency will help us to recover some of the possible impact of lower payment for MMTA and PDGM. All right, so when you look at the percentage of periods by clinical group, this is from CMS's data, you see that MMTA, when they looked at all the diagnoses from 2017 that were used for claims payment, they saw that most of those diagnoses did fall into the medication management, teaching, and assessment category. That was over 63% of our patients. Behavioral health was 3, wounds were just over 10, neuro rehab was 8, musculoskeletal was just over 10, and complex nursing was only like 3.5. So in CMS's mind, this again, the data showed that those complex patients were really not getting the same access to care. All right, let's look at the functional groupers between the two payment systems. In home health PPS, functional is based on OASIS items again, and those functional levels come from the 6 OASIS items and put the patient into a functional 1, 2, or 3, which is low, medium, or high, and then each of those groupers had its own points threshold. Now, in PDGM, there will still be, based on OASIS items, 3 functional impairment levels. Those OASIS items will continue to calculate points to put patients in a low, medium, or high functional category. Currently in home health PPS, the items that weigh for functional category are dressing the upper and lower body, bathing, toilet transferring in general, and then ambulation. In the PDGM groupers, you're going to see that M1800 grooming is also added, dressing the upper and lower body, bathing, toilet transfers, ambulation, locomotion, and they've also added 1033 risk for hospitalization, because if that patient's a high risk for rehospitalization, clearly there will be a less functional status and more resources going to keep them out of the hospital, most likely. The comorbidity adjustment. The way they say this in data, or at least in literature that's published, is that under home health PPS there was no comorbid adjustment. But in reality, when you look at those top 6 diagnoses codes that went into the clinical category, there was somewhat of an adjustment based on whether or not that top 6 diagnoses contributed points to the clinical category. If they didn't, of course, you didn't get more points, which indicates you didn't get more money. But if you had 6 different payer groups or comorbid conditions in the top 6, then certainly that calculated into more money. But as far as it being labeled as a comorbid condition or comorbid condition adjustment, that was not something that we currently have under home health PPS. Under PDGM, we will get a secondary diagnosis scrubbing. Those diagnoses that fall in spot number 2 all the way down to spot number 24 will be scrubbed when we submit our claims, and CMS will look to see if any of those diagnoses are on the comorbid list. If there are no diagnoses that are in the comorbid list, then that means you won't get a comorbid adjustment. If there's at least one, you'll get a low comorbid adjustment, and if there are 2 or more comorbid, then you will get a high comorbid adjustment. And then we look in the comorbidity categories. There are actually 11 heart disease categories that will fall onto the PDGM comorbid category list, 9 respiratory disease subcategories, 12 circulatory and blood disorder categories, 4 cerebrovascular diseases, 9 GI disease categories, neuro and associated conditions. There are 11 subcategories of diagnoses that will fall there, 6 endocrine, 24 neoplasm, 5 GU and renal, 5 skin, 5 musculoskeletal diseases or injury subcategories, 11 behavioral, and 4 infectious diseases. And we'll get into that more in the future on other webinars. Again, non-routine supplies are a separate calculation in home health PPS, our current payment system. Those payments range from $14.62 to $570.48, depending on the answers in your OASIS. In PDGM, the non-routine supplies are going to be based on the estimated cost of visits plus the non-routine supplies recorded on claims. Now, where do they get that information? They're looking back from 2017 to the current data, and they're looking based on the diagnosis that's in primary and what the actual cost was to take care of that patient. That's kind of how they're figuring out how much resources were used and how much it's going to cost us. So the cost of non-routine supplies is generated by taking non-routine supply charges on the claims and converting those to cost using a non-routine supply cost to charge ratio that is specific for each agency. Again, your cost reports is going to impact this. When non-routine supplies is factored into the average resource use, that establishes your case mix weights. In PDGM, non-routine supplies will still be paid prospectively. You're still going to get some money on the wrap and final, but there's no separate case mix adjustment like there is in PPS. Again, the 30-day period is going to be grouped into one of 432 home health resource groups under PDGM, and that information comes from the admission source and timing, your clinical grouping, your functional impairment level, and your comorbidity adjustment. Then they're looking at the 30-day periods. We'll bill a wrap for the first 30 days and a final, and then we'll bill a wrap and a final for the second 30-day period. When they get the final bill, or the claim as we call it, they're looking to see if the number of visits during that 30-day period is below the LUPA threshold. Now, here's the fun part about this. Under home health PPS, it's a standard 4-visit LUPA rate. Under PDGM, each of those 400 plus categories will have its own LUPA threshold. Those LUPA thresholds, depending on what category clinically the patient's in, can range anywhere from 2 to 6 visits equaling a LUPA. So when they say here they're looking at the number of visits during the 30-day period below the LUPA threshold, is it below that or not? If it is below, then you're going to get paid a LUPA. If it's over the LUPA threshold, then you get paid the full episode amount just like we do now, okay? And remember, your LUPAs are paid differently because if you have a LUPA, then rather than getting paid the whole episode amount, you get paid the number of visits times the national per visit rate to equal a per visit amount for each of those disciplines. And the total of that is added together, and that's how much you get paid. That could be the difference between, say, $1,600 in a 30-day episode to $250, right? So we have to be really careful about our LUPAs under PDGM. They also look and see if the patient was discharged and readmitted or transferred between agencies within a 30-day period. If so, that would be a PEP. If not, you get the case mix adjusted payment, further adjusted by the area wage differences in your labor portion and so on, the rural add-on, so on. All right, if they're not discharged and readmitted within a 30-day period, they look to see if this is now a high-cost 30-day period. So your outlier payment is based not on 60 days, but on the 30-day period. Is it an outlier payment, yes or no? And if it is, they'll adjust the payment accordingly. If it's not, if this is just a standard, we don't have a LUPA, there's not a PEP, it's not an outlier, then you're going to get the final payment for your 30-day period. Again, we're just going to revisit the LUPA here under Home Health PPS. A LUPA is fewer than 5 visits made in a 60-day episode. Under PDGM, the LUPA threshold varies for each payment group, and it's different for each 30-day payment period on top of that. So what I'm saying here is not only could your LUPA threshold vary between 2 and 6 visits per 30-day period, it could change. You may have one LUPA threshold in the first 30-day period and a second LUPA threshold in the second 30-day period. Again, that LUPA threshold ranges from 2 to 6 visits, depending on the grouper. Now, as far as your payment adjustments, as we've already talked about, you still have outlier calculations, you still have PEPs, and you still have LUPAs. The difference is the outliers and PEPs, instead of being figured on a 60-day payment period, they're now calculated on a 30-day payment period. All right, then we also have considerations regarding wraps. When we start talking about billing under PDGM, the first thing that we've already realized is that your billing is going to double because for each of the 30-day payment periods within a 60-day episode, you're going to have to submit a wrap and a final claim. Now, the only thing that's a little bit different are for those agencies who became certified on or after January 1st, 2019, they're submitting a non-payment wrap every 30 days. What does that mean? That means they're having to go through the process of submitting a wrap to show that this patient is under their care, but they're not getting paid wrap money. So if you're a brand new startup, you're not getting wrap money, request for anticipated payment. You're not able to get your money until you submit your final claim. Wow, those of us that have been around a while, can you imagine that? Agencies that are certified before January 1st, 2019 will continue to submit wraps and continue to get split payment. And they will continue when this goes into PDGM. Agencies that are certified before January 1st, 2019 will be receiving wrap money that will still be split 60-40 for an early episode the first 30 days and then a 50-50 split on subsequent 30-day periods afterwards. If something happens with payment and you need to do an appeal under PDGM, because the assignment of payment classification will be performed by the claim system based on data reported by the agency on the claim or the corresponding patient assessment, then if you have to appeal your payment, you would have to correct the information on the claim and or the OASIS to change the assignment of that patient classification and resulting payment. What does that mean? They're saying that if you see that your payment is wrong, you have to do kind of like what we do now, go in and if it's a key field versus non-key field error, cancel and or send an amended OASIS and claim, which will have to match. Don't forget your OASIS, your plan of care, and your claim all have to match. You'll have to correct that information to make sure that the patient falls in the correct payment category. You would submit a correction OASIS assessment and subsequently adjust your claim after the corrected assessment is accepted, or correct the payment-related items on the claim, like your occurrence code, your diagnosis code, and so on, and then submit the adjusted claim. So that process really doesn't change under PDGM. Some other just random thoughts and other notes to make sure that you're aware of. Because traditional Medicare is mandated to participate in PDGM, Medicare Advantage plans, however, they're private plans. They're privately managed, and because they are privately run, your Medicare Advantage plans get to choose whether or not they're going to change their payment models to mirror PDGM or not. So as you're contracting or renewing your contracts with Medicare Advantage plans, your Medicare HMOs, that's one of the questions you're going to want to ask them. Are they going to continue to practice in a per visit nature, which is how most of them pay? You know, they will pay you per visit, and you have to get an approval and submit your plan of care, and they have to approve the visits and so on. You're going to want to ask them, are they going to continue that current model, or are they going to switch over to the PDGM philosophy? And you'll want to make sure that you have a valid contract that states that in writing. PDGM will not have any impact on Medicare secondary payer process. Also to note, I learned this in the PDGM NAC Roadshow. I had missed this somehow or the other. TRICARE is mandated by law to follow Medicare requirements. So if you take TRICARE patients, they will also be following PDGM rules. All right, so let's think about some strategies for success under PDGM. We've talked about the basics of how the payment system is structured. Now we need to start thinking about, as you dig into this information, looking at how you manage your patients, because that's going to be a big deal. Making sure we're avoiding LUPAs, making sure we're providing efficient care with good outcomes, making sure that if we've always provided therapy for these patients, that we continue to provide therapy. We just do it in a way that is sensical for the patient, right? So currently in home health PPS, we see that we typically front load our visits within the first 30 days, and then at the end of the episode, we taper those visits down. Now, I want you to think about, and when you get in, start digging through your diagnoses and your categories and seeing where your patients would fall under PDGM. If you took that same model and knowing that your LUPA threshold could be different in the two 30-day payment periods, you're looking at, you might get a full 30-day payment in the first 30-day period, but then you might end up with a LUPA the second 30-day period. So you're going to want to really think about how you deliver care. And again, we don't want to begin gaming the system, because of that adjustment that we'll get for gaming the system. We'll start getting paid less. But you want to really look at, what does the patient really need? And we see that tied to the COPs, the regulations and the conditions of participation, that tell us that patients should have a patient-specific individualized assessment and a patient-specific individualized care plan. So we want to spend plenty of time from referral to the comprehensive assessment, doing a team approach, making sure we're not duplicating services, making sure we're doing this in a cost-effective way, and that we're providing what the patient needs, but we're doing it in a more streamlined manner, keeping up with things like our LUPA thresholds. Your softwares should be giving you the ability to monitor your LUPA thresholds within your scheduling center, for example. I know that's one of the things that we have on our roadmap. So for preparation for your agency, we need to know, first of all, that PDGM is really going to impact all the operations of your agency. It's going to impact your clinical, it's going to impact you financially, it's going to impact you operationally. So we really need to think about, first of all, forming up a committee, a PDGM implementation committee, where you can analyze your data and talk about in a multidisciplinary way how you can go about providing care on a more efficient and effective way. That way you save money from providing services that are, you don't want to duplicate services. You don't want to have situations where you have For example, a physical therapist going out and teaching the patient certain ways to bathe, and then the aide going out and just doing everything for the patient. Instead of that, you might instead look at the therapist and the aide meeting together, and the therapist showing the aide what they'll be teaching the patient to do, and having that aide reinforce that when they go in and bathe the patient, rather than doing it for the patient, coaching them on, now remember how the therapist said to do this and this and this? Let's have you do that while you're getting a bath. Those are the kinds of things that will make you more efficient and have better outcomes without expending more resources. Now, that committee would then need to educate all your personnel on the changes. They may not need as in-depth an explanation as you're getting here today. However, they do need to understand the basics of how this is going to affect them and their job specifically, and make sure it's job specific, okay? We also know that PDGM is going to rely heavily on accurate ICD-10 coding. Why is that a big deal? Because there are tons of diagnoses that will be not included in the PDGM grouping model. What I mean by that, there are many symptom codes, all of the R codes that we currently use, things like muscle weakness, M62.81, or ataxic gait, R26.0. Those codes will actually not be allowable codes under PDGM, which means if we use one of those codes in the primary diagnosis, we will not even get a generated HIPS and HERG score or payment, and that claim will return to provider for us to correct and get a more specific code. Again, we have to pay attention to that, so we want to really look at our current coding processes and accuracy. We want to start looking at what codes we're using, whether or not they're going to be included as acceptable diagnoses under PDGM, and if not, start educating our referral sources to make sure they understand that we need specific information. We want to make sure our referral sources are educated, as well as our referral intake staff, so that they know what to look for and start getting that information early on. We also know that the number of billing transactions will increase due to shorter payment periods, so we want to look at our current billing processes and timelines. Especially, we want to look at our orders management and getting those orders back timely and getting notes in timely, and making sure that those things are in place so that our face-to-face encounter, certification, all of those things are in the patient's chart so that we can bill as timely as possible after that 30-day period has ended. We know that therapy utilization is no longer a payment characteristic, so we really need to look at how we're using therapy now. We don't want to knee-jerk and stop seeing patients for therapy that we've always seen for therapy. That certainly would just reinforce the thought process that we're just out here gaming the system. We need to make sure that therapy is provided for the patients who need therapy, the number of visits, and correctly assess and make sure that therapy is utilized as it always has been. Make sure that we have clinical competency on assessment and case management, and that we use technology to assist us. Because we really have to think about the fact that when we start adding a new payment system and new processes, those will actually put a spotlight on poor processes, poor assessment, poor case management. If we're out there spending an hour on a start of care with a patient and we're not getting a clear picture of their medication and their socioeconomic status and what the reason is for us to be there, and formulating a really drilled down individualized care plan, it's going to be really hard to get out there and actually deliver a very individualized, efficient care plan as well. All right, so CMS's Education Plans, they're trying to help us understand what's going on. They are updating the Home Health Agency billing chapter of the Medicare Claims Processing Manual. You'll find that in the online manuals under the CMS website for home health. There are also lots of educational publications that have come out and will continue to, such as your MLN Matters, your YouTube videos, CMS announcements, and your MAX website articles. They've also established an email that individuals can send questions to. I do know people that have sent in questions and got a pretty timely response for PDGM questions, and that email address is homehealthpolicy@cms.hhs.gov. Lastly, I've added for you some resources for this presentation if you wanted to go back and read more about the home health payment reform. There is a national provider call that is archived from January of 2017. There's also several from January of this year. You've got your home health care service payment system revision October 2018 with a link there. And that's the MedPAC basics and what their recommendations are. And then there's a booklet about home health PPS if you want to know more about how we're currently paid so that you can understand how we're going to be paid in the future. Again, this is Jennifer Gibson Osburn. I do hope that you've learned something today from us here at Axxess. We certainly appreciate the fact that you turn to us for your educational needs and for your solutions to help you transition into PDGM. Please stay tuned to us. Make sure that you go and look at our PDGM website at axxess.com. We will continue to put all kinds of great tools up for you. A PDGM roadmap and questionable encounter codes list is already available, as well as the basics of PDGM and different infographics. We will continue to update and add information to that in the coming months. And we want you to be successful, because if you're not successful, we won't be successful. We won't be here without you. And more importantly, if you're not in business this time next year to take care of those patients that you serve, then that means someone is not getting the care that they deserve and need. So we want to make sure that we're your partner, and we think of ourselves as partners with you to make sure that you're successful in your delivery of care and business model. So thank you again for being here with us today. We hope you have a wonderful day, and no matter what job you do in home health, we understand that it's an important job. So thank you, thank you, thank you.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.